Hi, this is Professor Brenna Clark. Welcome to this lecture over diabetes for NU 202 Adult Health 1. We are just going to begin with a brief overview of the anatomy and physiology of the pancreas. And so it is located behind the stomach in the left upper abdomen. And it plays a few very important roles in the digestion of food and the processing of that food into nutrients for us to use. So it is actually divided into having two different types of functions. The pancreas has both exocrine functions and endocrine functions. So the exocrine function is that the pancreas is able to produce enzymes that aid in the digestion or the breakdown of food. What we are going to focus on today is the endocrine functioning of the pancreas. And with that, the pancreas actually produces a few different types of hormones that help to regulate glucose levels in the body. So those two hormones that are produced by the pancreas then are insulin and glucagon. And we'll talk more about those here in just a minute. So beginning with insulin then, this is one of the major hormones that is produced by the pancreas. And this is produced by the beta cells of the islets of Langerhans. And these islets of Langerhans are specialized tissues within the pancreas that are able to produce the insulin. So when the body senses a rising glucose level in the bloodstream, insulin is going to be released from these cells, and insulin acts as the key that allows the cell membranes to become semi-permeable so that the glucose can actually get into the cell and be used by the body. Okay, so I'm just going to repeat that one more time. The insulin that is produced by the pancreas as the body senses increased levels of glucose, the insulin is that key that then attaches to cell surfaces and opens up those membranes of the cells so that the glucose can get in and be used, which you can see over here on the picture to your right. When a low glucose level is present, the pancreas is signaled to release glucagon, which causes the liver to convert stored glycogen to glucose so that we can use it. So the pancreas actually has the ability to both lower glucose levels by secreting insulin or raise glucose levels by releasing that glucagon that then stimulates the conversion of glycogen to glucose by the liver. So when we talk about blood glucose and things that are going to make the glucose level in the blood increase, it is common to think about things like eating and drinking sugary foods or drinks that is going to cause that. But it is important to know that there are other things that can cause an elevation in glucose as well, especially as we care for patients in the hospital setting. And that is because anything that causes stress on the body can cause glucose levels to increase. So when we talk about stress on the body, this can be things like pain, just being hospitalized, infection, surgery, or trauma to the body. And anytime the body undergoes stress, it triggers the adrenal gland, which is part of the endocrine system, to release the hormone cortisol, which will also increase glucose levels. So this is why we monitor all patients' glucose when they're in the hospital setting, because we know some of the complications related to high glucose levels. So we want to make sure that we are monitoring that, controlling the glucose to the best of our ability so that we can decrease the likelihood or their risk for developing some of those complications. All right, so diabetes mellitus. So it is defined as chronic hyperglycemia. Okay, so this doesn't mean that an individual just has one elevated glucose reading, but chronic hyperglycemia or high levels of glucose due to the inability of the body to regulate glucose. Okay. So we mentioned previously that the pancreas has a couple different roles in helping to maintain those normal levels of glucose in the body. So this chronic hyperglycemia comes from that inability of the body to regulate those glucose levels. Now, there are two reasons or ways that the body can have issues with being able to regulate those glucose levels. The first reason is that the pancreas will either not produce any insulin or will produce a decreased amount of insulin. So if we have that lack of insulin production, that is going to decrease the ability of that glucose to get into the cells for it to be used. Because remember, that insulin is the key that allows it to do so. The other way that we can see chronic hyperglycemia is related to a decreased ability of the insulin to work. Okay? So the insulin is being produced, but now there is something keeping it from being able to attach to those membranes on the cells to open those membranes up to allow that glucose in. All right, so hyperglycemia then is the term that we use to describe increased blood glucose levels. We consider normal blood glucose levels to be 70 to 110. Again, different facilities will have different normal ranges, but 70 to 110 is pretty standard, is normal. So hyperglycemia would be a blood glucose level greater than 110 or 120. Then we have type 1 and type 2 diabetes. We also have gestational diabetes, which can occur during pregnancy, but that is something that you will talk more about when you get to peds and OB in a few semesters. So we are just going to focus on type 1 and type 2 diabetes today. Type 1 diabetes is used to describe that decreased or lack of insulin production. So with type 1 diabetes, the pancreas is not producing insulin as it should. And then with type 2 diabetes, this is when we have the insulin still being produced to some extent, but the insulin is not able to work in the body. And the reason that this insulin is not able to work is that the cells that insulin would normally bind to in order to let the glucose into those cells actually become resistant to the insulin. So it cannot attach as it normally would in order to let the glucose in. So patients that have diabetes, our goal of treating these individuals is to help maintain normal glucose levels the best way possible. And the reason being is that when individuals have high levels of glucose, especially chronically high levels of glucose, they are at an increased risk for a multitude of different types of complications. So we want to try to prevent that. With diabetes, we also want to monitor patients for hypertension and high cholesterol. Anytime a patient has those three things, diabetes, hypertension, or hyperlipidemia, they are at an increased risk for complications. So even though our main focus may be on the diabetes, we also want to make sure all of these comorbidities are equally controlled so that we are preventing any complications the best that we can. So how common is diabetes mellitus? It is estimated that there are about 30 million adults and children who have diabetes, and that's about 10% of the United States population. So it is very prevalent. Of that, is considered that about 21 million have actually been diagnosed, and that about 8 million are undiagnosed. So it's definitely something, again, that we are seeing more and more of, but we do believe there are still quite a few individuals out there that have diabetes but have not been formally diagnosed. About 1.5 million are diagnosed each year, and it is the 7th leading cause of death, not necessarily directly related to high blood glucose levels, but because of the issues that diabetes can lead to, so the other chronic health conditions that can develop if we don't take care of our blood glucose levels and maintain those. All right, so we are going to look more closely then at type 1 diabetes. And this is the less common type of diabetes when compared to type 2, but it impacts approximately 3 million people in the United States. What's unique about this type of diabetes is that it is diagnosed early in life. So typically in the teenage years, if not before. very uncommon that we see a diagnosis of type 1 diabetes, in the 20s or after. It is an autoimmune disease, meaning that the immune system is incorrectly attacking the pancreas, thinking that it's something that it shouldn't be. So the autoimmune disease causes that. And as the immune system attacks the pancreas, it destructs those beta cells in the islets of Langerhans. So that decreases the ability then of the pancreas to produce insulin as it should. So the result, or when an individual has type 1 diabetes, they are going to have significant reduction or complete resolution of their production of insulin. So potentially no insulin being produced at all. So these are the individuals who are going to be insulin dependent. Because they don't produce any insulin, we have to have that insulin in order for us to use glucose in the body. All right, and then we have type 2 diabetes. This makes up approximately 90% of the individuals with diabetes. And again, the prevalence of this is increasing significantly. Insulin is produced with type 2 diabetes, but the cells are resistant. So again, that insulin that's being produced is not able to attach to the membranes of the cells as it normally would, so that glucose is not able to get into the cells to be used. Something that is important to note with this is that early on in this disease, when this resistance is first beginning, the pancreas will actually try to increase insulin production because the body again senses when we have levels of glucose in the body that are too high. So the pancreas tries to increase insulin production to help with these high levels of glucose. But eventually what happens is the pancreas will wear out and insulin production will decrease too. So these individuals typically start with that cellular resistance to insulin, but then over time the pancreas will end up decreasing its ability to produce insulin as well. All right, so this slide just kind of pulls together what we've been talking about in comparing type 1 and type 2 diabetes. Like I said, with type 1, it's typically juvenile onset, so typically onset younger than the age of 20 or 30. We have abrupt onset with type 1 diabetes. So these are symptoms that can come on very rapidly and abruptly. Commonly, these individuals will present with things like thirst, hunger, increased urine output, and weight loss is also common. And we'll talk about these symptoms and why these symptoms develop here shortly. But these are all related directly to high levels of glucose in the blood and then the glucose not being able to get into the cells. It is not uncommon for a viral infection to precede diagnosis of this. Again, that viral infection or any type of infection is going to be a stressor on the body. It's going to cause the blood glucose to elevate even higher than it normally would be, which is what sometimes makes those symptoms even more prominent or noticeable in these individuals. These patients are typically not obese, and they will be dependent on insulin, like I said, because remember, with type 1 diabetes, we have significant reduction in the production of insulin or no insulin being produced. So we have to replace that insulin. All right, type 2 diabetes then is typically adult onset. We see the most diagnoses beginning in the 50s, but it can occur earlier. And as we see an increase in obesity and other health conditions, we are seeing earlier and earlier diagnoses of type 2 diabetes. Frequently early on in the disease process, we will not see any symptoms, but as that insulin production begins to cease, as the cells become even more resistant to the insulin, we will start seeing some vague symptoms. So it could be thirst, fatigue, blurred vision, but sometimes we don't even know that the patient has diabetes until they start demonstrating some of the complications or signs and symptoms of complications that can occur from diabetes. So things that have to do with the vascular system, neurological complications, so on and so forth. So with type 1, we see abrupt onset. We see very specific signs and symptoms related to those high levels of glucose. With type 2, we may see no symptoms or vague symptoms, or we may not even know that the individual has this until the symptoms of those complications begin occurring. 60 to 80% of individuals with type 2 diabetes are obese, and insulin is going to be required in about a third of these patients. Again, the reason being is that early on in the disease, yes, the cells are resistant to insulin, but the pancreas is trying to produce more and more insulin to make up for those high levels of blood glucose. But eventually that pancreas is going to become tired. Its ability to produce that insulin may cease. So now we're going to have two issues. Not only are the cells resistant to insulin, but we may have absolutely no insulin production by the cells of the pancreas as well. So we may need to provide some supplemental insulin with that. All right, so when we are assessing a patient, either to determine if they have diabetes or we're assessing an individual that we already know has diabetes, there are going to be some specific laboratory values that we want to pay close attention to that are either going to tell us about their current blood glucose level or about their glucose control over a longer period of time. So when we think about blood glucose levels, we most commonly think about what we call the fasting blood glucose. And this is that blood glucose level that we gather whenever we obtain a routine blood draw on a patient. When we say fasting blood glucose, we mean that an individual does not eat or drink anything for 8 hours prior to this lab being drawn, which is why in the hospital setting, these labs are drawn very early in the morning, hopefully before the individual has eaten breakfast. Normal fasting blood glucose level, again, is going to differ based on the facility that you're in and what source you are looking at, but typically it's between 70 and 100 or 70 and 110. Hypoglycemia is if that blood glucose level falls below 70. And hyperglycemia is if that blood glucose level is above that top normal range level, so either 100 or 110. All right, and both of these abnormalities can have effects on the body from either having not enough glucose in the bloodstream, because we need glucose in order for our brains to function and for our muscles to function, so on and so forth, or we can have complications related to too much glucose in the bloodstream as well. So our fasting blood glucose level tells us what an individual's glucose is at that said point in time. Then we also have the glycated hemoglobin, or we can also call this the glycosylated hemoglobin. And this is a form of hemoglobin that is used to monitor average plasma glucose concentration over the past 90 days. We also call this the hemoglobin A1C, so be sure that you do not get this confused with the hemoglobin that is on red blood cells that help to carry oxygen. This is completely different in its purpose, but this helps to tell us the average blood glucose levels over the last 3 months. For a normal, healthy individual without diabetes, normal is going to be a hemoglobin A1C of 5.5 or below. For individuals with diabetes, we might not expect them to have that normal level of 5.5 or below. That may be our ultimate goal, but there are some individuals that have a really hard time controlling their blood glucose level. So we might say that a 7 or below is our goal for that patient. So a lot of times the goal for individuals with diabetes is going to be unique based on what is going on with that individual. So when you are caring for a patient with suspected diabetes, there are a couple different processes that we are going to go through in order to determine if that individual has diabetes. Again, this is not diagnosed based on just one abnormal fasting blood glucose level, but we are going to be looking at several different things to make sure that we have an accurate diagnosis of this illness or disease. So one thing that we are going to look at is that fasting blood glucose or the fasting plasma glucose. Again, when we do this, we want to make sure that patients have not had any caloric intake for 8 hours. And we also ask them to not take any medications prior to this blood draw when we are doing it for potential diagnosis of diabetes. In order to be diagnosed, then, they have to have 2 separate blood glucose readings of greater than 126. Okay, so not all that elevated, but again, the goal with this is making sure it's on 2 separate occasions and that they have followed those fasting rules prior to this blood draw. All right, we can also do some screenings to detect prediabetes and type 2 diabetes. So in individuals who are obese, because we know that patients with obesity are at higher risk for developing type 2 diabetes, these individuals are going to be encouraged to have those screening fasting plasma glucose drawn so that we can help to determine if they do potentially have either prediabetes, which means just some slight insulin resistance or the start of insulin resistance, or if they are actually developing type 2 diabetes. So this would be encouraged for those patients who are at high risk, because the sooner we start treating these high levels of glucose, the greater likelihood or the greater chance we have of reducing their risk of those complications related to it. And then once an individual is diagnosed with diabetes, we are going to look at a couple different things to just determine how well it's being controlled, because diagnosing it is just half the battle. Then we need to make sure that the individual is able to control those blood glucose levels, because the complications we're really concerned with are going to be related to poor control or lack of control of those blood glucose levels. So we are going to do periodic glycosylated hemoglobin, or that hemoglobin A1C testing to make sure that those levels are where they need to be. Just to give an example, I have cared for patients numerous times that come in and say, well, my blood glucose has been running really good at home. It's normally 120, 130, and that's really good for me. But then we look at their hemoglobin A1C and it's a 10 or 11. So that tells us, okay, well, your spot checks, those fasting plasma glucose tests might be great, but as you look at their control over the past 90 days, we find, okay, well, that's actually really out of whack. So I don't think the glucose control has been, as great as we thought it had been. We can also look for ketones present in the urine or in the blood. And whenever an individual has lack of blood glucose control, so the glucose rises significantly, but it can't get into our cells as it should, our body starts breaking down fats to try to produce the energy that we need. When fat is metabolized or broken down, it produces ketones. So we can do assessments to find whether or not ketones are present in the urine, in the saliva, in the bloodstream, that could tell us that fat is actually being broken down because we can't use that glucose. So that's another potential indicator for poor glucose control as well. All right, so as I mentioned earlier, hyperglycemia is defined as a blood glucose level of greater than 110 or 120 in someone who has been fasting. And it is considered an acute complication of diabetes because typically in a patient that does not have diabetes, we are not going to see a fasting blood glucose level that is that elevated. So when we see that, that's an indicator that our body isn't producing the insulin that we need in order to maintain normal blood glucose levels. Prior to being diagnosed with diabetes, especially type 1 diabetes, symptoms related to hyperglycemia are typically what cause an individual to get assessed by a physician and eventually diagnosed with diabetes. Our concern with hyperglycemia is that if an individual has chronic hyperglycemia, so just poor control of blood glucose leading to chronically high levels of glucose in the blood, what can happen is we can actually see these high glucose levels damage the inner layer, the endothelial layer of the blood vessels. As this damage occurs from the high levels of glucose, this is going to lead to inflammation. And as we talked about during the inflammatory process unit, if we have this inflammation that's occurring over and over and over again, eventually this is going to cause scarring to occur inside those blood vessels. It causes the blood vessels to become permanently damaged and narrowed as a buildup of this scar tissue. So the complications that we see related to hyperglycemia all tie back to this damage to the blood vessels that can occur. Think about what could happen if the blood vessels in our brain are deteriorating or scarred and narrowing, or the blood vessels of our heart, or the blood vessels of our kidneys, okay? Blood vessels in our extremities. So perfusion can be greatly compromised as a result of this scar tissue and the narrowing that occurs in these blood vessels as a result of chronic hyperglycemia. So this is why we are so concerned with controlling these levels of glucose. When we pair chronic hyperglycemia with hypertension and or hyperlipidemia or high cholesterol, these are both conditions that can also cause damage to the blood vessels. So when an individual has more than one of these, that just further increases their risk for complications related to that vessel damage that can be occurring. All right, so when we're talking about signs of hyperglycemia or high levels of glucose in the blood, we call the classic signs the 3 Ps, and that is polydipsia, polyuria, and polyphagia. Polydipsia means extreme thirst. Polyuria means an increase in the amount of urination, so urinating a lot of urine. Right? So polydipsia and polyuria kind of go hand in hand. But when we think about glucose, glucose is considered a solute. And so when glucose is in the blood in high concentration, it increases the concentration of the blood. Okay, so when you're looking at the picture over on the right-hand side of your screen, on the left-hand side, you can see how concentrated that is with those glucose molecules, which are your red molecules there. So glucose is a solute and it increases the concentration of the blood. With this increased concentration of the blood, the body senses this as dehydration. So it urges the body to need more water. And as a result, then that triggers our thirst center in the brain to say, hey, you need to be drinking more water, you're dehydrated. So that is what causes the polydipsia, or that extreme thirst. Right? The polyuria comes as a result of the kidneys trying to excrete excess glucose. So as we mentioned during the renal lectures, one of the responsibilities of the kidneys is to monitor for glucose in the bloodstream. And when we get above usually 180, the kidneys are going to try to start dumping that glucose into the urine. Because that's one way that we try to get rid of the glucose and maintain those normal levels. So that results in the polyuria, or actually voiding a lot of urine because the kidneys are trying to dump that excess glucose. Polyphagia is an increase in appetite. As I mentioned before, if we do not have insulin, or that insulin cannot bind to the cells, then glucose is not going to be able to get into the cells so that we can use it. The body is going to perceive this as starvation, which then increases one's appetite, leading to that polyphagia, or an increase in appetite. Unfortunately, when we increase our appetite and an individual is taking in more and more, this is only going to increase the level of glucose in the blood. So as a response to that lack of glucose in the cells, the pancreas is going to release glucagon, which causes the glycogen stores in the liver to be broken down to produce glucose. So is this a good thing? No, because this just adds to the glucose that's in the bloodstream that can't get into the cells because of lack of insulin. As the body continues to sense starvation, the body is going to break down fat tissue and cause weight loss. Okay, so polydipsia, polyuria, and polyphagia, 3 P's, the classic signs of hyperglycemia. All right, other manifestations that we can see related to hyperglycemia are going to be blurred vision. And this occurs because glucose can actually accumulate in the aqueous fluid of the eyes, changing the osmolarity and causing vision to become blurred. And we can also see electrolyte imbalances that result due to the high levels of glucose in the bloodstream. This causes, again, water to be drawn into the bloodstream, and it can cause dilution of that, making other electrolytes like sodium, potassium appear lower than they really are as a result of that dilution. So here is just kind of a visualization of some of the common signs of hyperglycemia. So we talked about frequent urination, hunger, blurred vision. The drowsiness can occur as well. Typically, we are talking about very high levels of glucose with that. Dry skin and nausea are a little more vague and related to chronic hyperglycemia. Something else that we commonly say with hyperglycemia is, in addition to that dry skin, it's sometimes warm as well. When we talk about low levels of glucose, it's going to be the opposite of that. So warm and dry skin is common with hyperglycemia as well. So again, our goal with diabetes is going to be to control those blood glucose levels, to maintain them at a normal level or as close to normal as we can, because again, high levels of glucose, especially chronically, is going to cause that inflammation inside the vessels and eventual damage to the vessels that will be permanent. So there are a couple different ways that we can treat diabetes. It's going to go back to what the cause of the diabetes is in the first place. If we have a patient who has lack of insulin production or a decreased amount of insulin production, we are going to need to provide them with insulin. One thing that is important to note is that when we give insulin, there are several different types of insulin that we can provide. And these different types differ in their time of onset. So how quick does it take to kick in once we administer it? The peak, so once it's kicked in, when is it most effective when it's in the body? And the duration, so how long does it last once it's in the body? So when you are preparing for clinical and looking up these different types of insulin, it is critical that you understand what type of insulin it is and how it's going to work in the body, so that we know when the patient should receive that insulin in relationship to when they eat. Okay. For instance, if we are administering what we call rapid acting insulin, this is insulin that kicks in within 5 to 15 minutes and is going to drop that blood sugar relatively quickly. If we are going to give that insulin to someone, we want to make sure that they're going to be eating, let's say, breakfast soon. We don't want to give this insulin to them when they aren't going to be eating for an hour and a half, because their blood sugar is going to have dropped and they aren't going to be eating to help maintain that balance. Okay, so we just want to make sure that we understand how the insulin works, when it's going to kick in, what that effect is going to be, so that we know when to give it or when to have the patient eat. All right, in addition to insulin, we can also give our oral hypoglycemics. So these are medications that are taken orally, or PO, in order to typically help with that resistance that can occur. So we have our biguanides. Okay, an example of this is metformin. And the way that this classification of medications work is that it decreases glucose production by the liver. So it decreases glucose production by the liver, and it increases cellular sensitivity to insulin. So it works a couple different ways to help maintain those normal levels of glucose. It decreases glucose production, but it also helps those cells to become more sensitive to insulin so that it can attach and allow glucose into the cells. Metformin can cause some gastrointestinal upset. That's a common side effect with this. There is one key thing with metformin, and that is that we need to hold this medication for 48 hours prior to any IV contrast. And we also need to hold it usually 24 to 48 hours after receiving contrast as well. So this could be done in things like surgery or just a CT scan with contrast. But if we administer this medication and the patient receives dye, IV contrast dye, it can cause them to have kidney issues, so to develop a kidney injury, or it can lead to what we call lactic acidosis as well. So do remember that metformin needs to be held to prevent those complications when a patient is receiving IV contrast dye. All right, and then we have our sulfonylurea class. Our prototypical drug for this is glyburide, and this increases insulin that's released by the beta cells. So it's not an insulin supplement, but it helps to increase the insulin that's being released by the beta cells of the pancreas. It can cause hypoglycemia and also weight gain are common side effects of that. All right, so when a patient is hyperglycemic or their blood glucose levels are elevated, there are a couple other things that we are concerned with. One I already mentioned, but that's a dehydration. So again, as that glucose increases in its numbers in the blood, we are going to see an increase in blood concentration as a result of that, which leads to dehydration, okay, because we have an imbalance between the solute and solvent concentration in the bloodstream. So dehydration can result. As I mentioned earlier too, when we have lack of insulin, the body senses that it is starving because the glucose cannot get into the cells. So again, the liver then begins breaking down fats to try to produce energy, because if glucose can't get into the cells, then we aren't going to have the energy that we need to survive. So as those fatty acids or those fats are broken down, ketones are going to be produced as a byproduct of that breakdown. So basically, the ketones are a result of the breakdown of those fatty acids. Ketones are considered acids. So when they are in our bodies, it can cause what we call metabolic acidosis, which could eventually kill someone if not treated rapidly. When an individual is acidotic or they have too much acid in their body, one thing that can result are rapid and deep respirations. So the individual starts breathing deeper and more quickly, trying to get rid of CO2 or carbon dioxide, because that is another type of acid that we have. So that's our body's way of trying to compensate for that increase in ketones, which are acids. We're trying to get rid of that carbon dioxide, which is another acid, to try to bring that pH back to normal. So those rapid and deep respirations are what we call Kussmaul respirations. And individuals will also have fruity or malodorous breath, and that is a result of those ketones as well. The ketones let off a fruity or malodorous smell. Okay, so that's a result of the breakdown of those fatty acids, which is a result of the body sensing that starvation because the glucose isn't able to get into the cells. And then we can also see hyperkalemia or increased potassium levels. With lack of insulin, potassium also can't get into the cells, so it remains in the bloodstream. So think about the effects of what hyperkalemia could be on the body as well. All right, so looking a little more closely at the different types of insulin then, this is something that you need to be familiar with. So we have 4 different classifications of insulin. We have rapid acting, short acting, intermediate acting, and long acting. I did put up there the onset, so that's how quickly the medication takes effect, and when it peaks. So when is it at its highest level or the most effective um, level in the body. So again, we want to be aware of these things, these different levels, and think about how that is going to affect an individual as far as when we administer it. Is it going to drop their blood sugar quickly? Is it going to work to sustain their blood sugar over 12 hours? So just thinking about that with individuals. Like we mentioned way back when in the second week of lab this semester, it may be necessary at time to mix insulins. Big reminder with that is that we cannot mix those long-acting insulins that we were just talking about. But otherwise, the medications or the other types of insulin can be mixed with others. So this would be a good time to go back and review the steps for mixing insulin. I'm sure you don't want to think about that. But it'll soon be finals time, and that will be on the final as well. So I would go back and review the appropriate steps for mixing insulins, things to do, things not to do, and just kind of highlight or star that reminder that long-acting insulins cannot be mixed with others. All right, so something that you will hear commonly discussed with diabetes is exercise. And exercise is something that we encourage in all patients with diabetes. Now, that doesn't mean that we tell patients that, maybe don't exercise at all to go out and start training for a marathon, but we do encourage patients to do at least a moderate amount of exercise, even if it's not real intense. Because we have found that when an individual exercises, it actually enhances or promotes glucose being able to move into exercising muscle and into the cells. So it improves insulin sensitivity by the cells so that we can actually use that glucose more readily. And then the other benefit to exercise with diabetes is that exercise is going to help reduce the likelihood of developing hypertension. It's going to help to control hypertension and hyperlipidemia. So we are just going to encourage this for some of those cardiovascular benefits as well. As patients do begin exercising, there are some things that we want to be sure that we remind patients about. One thing that we want to remind patients about is that glucose can remain lowered for several hours after exercise. So like I mentioned, when an individual exercises, glucose is going to move into that exercising muscle, and it can cause the blood glucose to drop. So we want to remind patients that that can happen and that decreased glucose level can extend beyond that time of when they are exercising as well. So because of that, if you skip down to the third bullet point, we do encourage patients to consume an extra carbohydrate snack and usually a protein as well right before exercising, just to help with that decrease in glucose. We don't want them to bottom out. We just want that glucose to stabilize so that they can sustain that exercise. We encourage patients to avoid exercise if their blood glucose is elevated, greater than 250, or if ketones are present in the urine. If an individual tries exercising when these are present, that tells us the body could be in that starvation mode, and it could cause some pretty detrimental effects on the body if they try to exercise with that going on. All right, and then the final bullet point there, we do encourage them just to be prepared in case their blood glucose levels do drop. So to carry a carbohydrate source during exercise in case that happens. Okay, another acute complication of diabetes is in the opposite end of the spectrum, so hypoglycemia, or a low blood glucose level. And so the signs and symptoms that we see with this are going to be opposite of what we saw with hyperglycemia, but they're related again to the low levels of blood glucose, and blood glucose not getting to organs like the brain, which we need that constant supply of glucose in order for the brain to function. So the body recognizes that there isn't enough glucose in the bloodstream, which then causes epinephrine and glucagon to be released, and that activates the sympathetic nervous system, which causes a lot of the symptoms that we see. So shakiness, tachycardia, cool and clammy skin, dizziness, anxiety, hunger, blurred vision, weakness, headache, and irritability. So again, some of them are vague symptoms, but especially if we have a patient that we think might be hypoglycemic and they show, even just one of these signs, we want to be assessing their blood sugar and seeing if that is low so that we can treat that. Common causes of low blood glucose level or hypoglycemia. Too much insulin compared to food intake. So maybe we give their full dose of insulin at dinner, but then they decide they only want, their applesauce and not the full meal. So now that insulin that we gave them is going to cause their blood sugar to drop too low. Insulin injected at the wrong time compared to intake. So exactly what I was talking about earlier with giving that rapid acting insulin and then the patient not eating for an hour and a half. Wrong type of insulin at the wrong time. Decreased food intake or delayed meals. Delayed gastric emptying from gastroparesis. So gastroparesis can result as a complication of chronic hyperglycemia. It slows the emptying of the gastric contents into the intestine. And so when that happens, it takes longer for the glucose to be absorbed for us to use that. So that can cause hypoglycemia. Decreased liver glucose production after alcohol ingestion. Increased insulin sensitivity as a result of regular exercise and weight loss. And decreased insulin clearance from progressive kidney failure. So remember, the kidneys are responsible for filtering out insulin and breaking down insulin. So if we have issues with that, that insulin can actually build up in the body. So treatment of hypoglycemia. If you have a patient that is hypoglycemic, first thing that you need to do is assess your patient. Not only their blood glucose level, but what are you seeing when you observe that patient? If they are alert and talking, then we want to give the patient food. Okay, if they are able to safely take in food, then that's what we want to administer. We want to start with the least invasive first if they're able to tolerate that. So if they are alert, talking, coherent, then we follow what we call the 15-15 rule. And we are going to have the patient eat 15 grams of a fast-acting carbohydrate, and then we are going to wait 15 minutes to recheck their blood sugar. And when we talk about a fast-acting carbohydrate, we are referring to things like orange juice or low-fat milk. Okay, so we're going to have them eat or drink that 15 grams of carbs, wait 15 minutes, recheck their blood sugar. Okay, we're going to repeat that trend until their blood sugar levels are greater than 70. So let's say we check their blood sugar, it's 45. We have them eat or drink some orange juice. We recheck it 15 minutes later. Now their blood sugar is 55, but the patient's still alert, still talking, still, physically fine. We're going to repeat that step. We're going to have them eat another small amount of carbs and then recheck it again in 15 minutes. As long as they are alert and talking and stable, we're going to continue on that trend. Once their blood sugar gets greater than 70 milligrams, then we are going to add protein, so something like peanut butter and crackers. Carbohydrates work to quickly increase the glucose level. Protein helps to sustain a glucose level. So that's why we want to give both of those so they can balance each other out and sustain that normal glucose level. On the other hand, if the patient is lethargic, so difficult to arouse, unable to swallow safely or follow instructions, then we are going to give either glucagon or glucose to the patient. And we're going to do this either through injection, like an IM or subcutaneous injection, or intravenously administering that. So again, it depends on what that patient looks like, if they're alert, oriented, coherent, able to follow commands. So this just lists out the signs and symptoms that we were talking about between hypo and hyperglycemia, just so you can put it kind of in one picture here. So none of this should be new. I think we've talked about a lot of this as we've gone through. So just to review that for you there. Another hot topic with patients with diabetes is what to do if you're sick. A lot of patients think, or individuals think, I'm not feeling well, I don't really feel like eating, so my blood sugar is going to be fine. I probably don't need to check it, or I don't need to take my insulin. As I mentioned towards the beginning of this lecture, when an individual is sick or when the body is under stress, blood sugar is likely going to elevate as a result of that stress response with the adrenal gland and the production of cortisol. So we really want to educate patients that their glucose still could be elevated, and it's really important to still monitor their blood glucose and treat that blood glucose if it is elevated. Okay, so just because an individual is not eating, we still need to closely monitor it, and we may still need to give insulin. So when an individual is sick, we educate them on monitoring glucose every 2 to 4 hours. We also encourage them to stay hydrated and monitor urine for ketones, because that again could be a sign, if ketones are present, that there isn't enough glucose getting into their cells, and their body treats that like starvation and tries to break down fats to produce that energy, which is going to produce the ketones. All right, so we've talked about the acute complications of diabetes. Now we are going to go into more chronic complications related to diabetes. And all of these complications are related to hyperglycemia and chronic hyperglycemia, where we see the damage to the vasculature that occurs from high levels of glucose causing inflammation, eventually causing scar tissue and narrowing of the blood vessels. We divide this into microvascular complications, meaning that these are complications related to damage to the very small vessels, and macrovascular complications, which are complications related to the large vessels in the body. As far as microvascular complications, we have retinopathy, and this is damage to the blood vessels that feed the eye. So it causes visual dysfunction, like blurred vision. It can eventually lead to blindness if not controlled and treated. This also refers to nephropathy, so damage to the nephrons of the kidney related to the blood vessels of the kidney being damaged. And then neuropathy is nerve dysfunction that results from, again, the blood vessels that feed the nerves, that help those nerves to function, becoming damaged and causing injury there. Then our macrovascular complications related to diabetes, we're going to see coronary artery disease. So remember, the coronary arteries are the arteries that feed the heart. So these can become damaged. Cerebrovascular disease, so an increased risk for stroke related to the blood vessels being damaged that feed the brain. And then peripheral vascular disease, so referring to the vessels that feed the extremities. So with all of these complications, we are talking about damage to that endothelial layer of the blood vessels that then decreases the amount of blood flow to certain areas, whether that's to the eyes, to the kidneys, to the nerves, to the heart. Okay, so we're talking about decreased blood flow to these areas from that damage to the blood vessels. Okay, and this again just kind of summarizes what we've been talking about. So as we have that scarring from that inflammation that causes that narrowing of the blood vessels, causes a decrease in blood flow to certain areas of the body. Okay, that decrease in blood flow results in ischemia, or lack of oxygen. And then we see the complications related to that lack of oxygen. So again, when an individual has these changes occurring because of diabetes, but they also have complications like hypertension or high cholesterol, the damage to the vasculature is going to occur more quickly. and their risk for any of those complications is going to increase as a result of that. All right, so we're going to start with diabetic neuropathy. So as I mentioned, this occurs whenever we have decreased blood flow and decreased oxygenation to our nerves. So this again results from damage to and narrowing of the vessels that typically feed those nerves with oxygen. And if the nerves do not get the oxygen that they need, then they are not going to be able to function as they should. So typically the nerves of the feet and hands, so the furthest away from our heart, are going to be affected first. And the result of those nerves being damaged from lack of oxygen is going to be sensation changes. So most commonly we're going to observe numbness and tingling in those extremities, and sometimes even pain in those extremities too. And this all results from those nerves being damaged. Something else that we need to remember is that other nerves can be impacted too. So commonly we can see nerves of the GI tract being affected, nerves of the eye being affected. Gastroparesis is what causes that slowing of the GI contents being passed out of the stomach to the small intestine, and this results from that damage to the nerves. It can't speed up that process. So just keep that in mind. It's not just the extremities that we're thinking about here. Anything that can cause damage to the vessels, so smoking, alcohol use, hypertension, high cholesterol, can increase the risk and increase the rate at which this develops. All right, complications related to this. Obviously, if someone has numbness and tingling, decreased sensation, they are going to be at increased risk for things like falls. But these individuals are also at increased risk for development of sores. If you think about it, if your foot's numb and you step on something, you may not know that you stepped on something. So you may not know that you need to check your foot out and see if it's injured. Okay? So a lot of times this development of sores comes from the individual not even realizing that they injured themselves, not assessing that area frequently. So we encourage patients to check their feet daily, or to have someone check their feet daily if they do experience these sensation changes, so that they can recognize and do something about it if they develop a sore. This also is why these individuals are at risk for poor wound healing, because of that decreased blood flow, that decreased oxygenation to their extremities and to their skin. Another concern is the inability to differentiate between hot and cold, or the inability again to know if they've experienced pain or if they've had an injury. So we don't encourage these patients to take a really hot bath or shower, because if they stick their foot in to test the bath water, it could be scalding hot. They could burn their foot and not recognize it. Okay, then they could go ahead and sit down in that and really cause significant burns to their body. So we always encourage them to use another method to test that water to make sure it's not too hot. All right, so nursing care with neuropathy, things we need to think about, and some of this is what we've already talked about, but foot care, very, very, very important with patients with diabetes, because if they do experience neuropathy and those sensation changes, it's just very important that we monitor the feet and that we take those precautions to prevent injury to the feet. So we need to educate about that risk for foot ulcers and about that risk for impaired healing. We need to educate patients about monitoring their circulatory status. So monitoring if their feet are cold or not. That could tell us that they have some decreased circulation. We also need to educate that they may experience some loss of strength and that loss of protective sensations. So being able to differentiate between hot and cold, things like that. Patients will be educated to monitor their feet daily. So again, just checking to make sure there hasn't been an injury. They should wear specialized shoes with firm soles. Okay, so the flip-flops from Old Navy that are thin aren't going to protect the feet. Okay, so we want them to wear those really good shoes with firm soles, so that if they do step on something, they're at a decreased risk for actually having an injury from that. They may have a podiatrist trim their toenails. just to decrease the risk of any injury to the skin during that. And then not walking barefoot should be pretty self-explanatory. All right, and then diabetic nephropathy. So neuropathy was related to the nerves. Nephropathy is related to the kidneys. This again is the leading cause of chronic kidney disease. And basically now we're talking about the vessels in the kidney and the vessels that feed the kidney. So the arterioles of the kidneys that typically would perform waste filtration become damaged by that hyperglycemia. Risk factors for this include a history with diabetes, poor glucose control, uncontrolled hypertension, and a genetic predisposition too. So they might have diabetes, but they might also have a family history of kidney issues. So that's going to further increase their risk for developing diabetic nephropathy. What happens then is, as you know, we have to have a good blood supply to the kidneys for the kidneys to be able to filter that blood supply. So if those vessels are damaged that go to the kidneys, that's going to reduce the blood flow. And over time, that damage is going to interfere with the kidney's ability to filter adequately. So the inability to filter waste effectively declines, and that leads to kidney failure. In addition to that decreased ability to filter waste, all of the functions that the kidneys would normally do, so the production of erythropoietin, activation of vitamin D, all of those things are going to decline if we don't have that good blood flow to the kidneys. So that's just something to keep in mind with this. So think about what labs you would expect to be normal or abnormal in this individual. BUN, creatinine, potassium, GFR. So thinking about what we would need to monitor with that. Keeping in mind that they may not filter medications out completely. We may see, or we commonly will see, progressive loss of albumin and protein in the urine and a decline in that glomerular filtration rate. Okay, and that just tells us that the damage has been done to those vessels. They've become more leaky, so now we're losing things like protein into the urine that the kidneys normally wouldn't filter out. All right, and then we have diabetic retinopathy. Again, this results from damage to the arteries that feed the retina, so that supply the retina with blood and oxygen. The result of this is going to be blurred vision. We can have flashes of lights, floaters, but just abnormalities in vision or a change in visual acuity. This is the leading cause of new cases of blindness. And something to remember with this is that we talked about things like blurred vision being common with some of the acute complications of diabetes. So just keep in mind that we can have both acute and chronic issues related to visual acuity with diabetes. All right, so that was the microvascular diseases. Now we're just going to talk briefly about macrovascular diseases. And again, you should be seeing a trend in that with all of these complications, they all result from high levels of glucose impacting the inner layer, that endothelial layer of the vessels that cause scar tissue to build up and damage so that the vessels aren't able to perfuse the organs adequately. All right, so now we're talking about damage to the bigger arteries of the body. So those arteries that feed the heart, brain, and extremities that lead to ischemia and increased risk of thrombus development as well. So with coronary artery disease, we're talking about the coronary arteries that feed the myocardium of the heart. So as we have scar tissue developing here, patients are going to be at higher risk for decreased blood flow to the myocardium, which increases their risk for things like a myocardial infarction or a heart attack. Cerebrovascular disease, now we're talking about the vessels feeding the brain becoming narrowed or clogged, and this increases the risk for an ischemic stroke. And then with peripheral vascular disease, this is the narrowing of the arteries that feed the extremities. So this can further increase the risk for developing things like neuropathy that we were talking about. So when we are educating patients, whether it's a new diagnosis of diabetes or they just need a refresher on some of the information, there are some certain things that we may need to cover with them depending on their treatment regimen and depending on their risk factors. So we need to educate them about how often they're supposed to check their blood glucose. For some patients, it might be once daily that they're supposed to check that. For others, it may be ACNHS, so you want to review what ACNHS means. We also want to talk to them about what to do if their blood glucose is low or high and why it's important to control blood glucose and make sure it's maintained in those normal ranges. We may need to talk to them about how to store their insulin. Some types of insulin need to be kept cool. Some need to be kept at room temperature. We may need to educate them on giving themselves insulin injections or having a family member be able to give themselves injections, whether that's using a regular syringe or an insulin pen. We need to make sure that they are aware of how to do that and can actually demonstrate doing that before they leave the facility. We want to make sure that they can care for themselves. Infection control measures. So remember that high levels of glucose in the body is a great medium for bacteria to come, proliferate, and cause an infection. So not only do things like decrease blood flow to an area increase that risk for poor wound healing, but that also is a great medium for bacteria to proliferate and cause an infection too. So talking to patients about how to decrease their risk for infection and what to monitor for with infection as well. And there are some diet recommendations that we make as well. Those are listed here for you. You don't need to memorize the percentages or anything, but you should kind of keep in mind and have an idea of what we want patients to avoid and eat more of. And that's going to help them ultimately keep the best control of their blood sugar. Again, we're going to make these recommendations on a patient-by-patient basis, so it's going to be individualized. But these are some of the general guidelines that we provide for these patients.